All right, what's up, psychosocial class? I want to make this kind of a random video. It's in response to a question, but I think that I think it's gonna be helpful for everyone, and I'll try to tie it in a little bit to grief and loss. But it's mostly about therapeutic communication, and you guys are in the psych class right now, so doing psych clinical, which I know is pretty unstructured and is a lot of just sort of sitting and talking to people. And you can have your sort of focused, assessments and interventions that you do, but those don't tend to take very long, and then you're sort of left with the rest of the 3.5 hours or 8.5 hours. I don't know what was that you have left on the day, and so you just kind of have to keep it conversational and social, and that's fine. That's sort of what we're able to do in clinical. And so, but I know that with some symptoms, some symptomology, that sort of unstructured amount of time can be hard. For instance, somebody who has mania or somebody who has psychosis. And a lot of sort of what we're telling you to do and not do in those conversations can be kind of hard to navigate. You can kind of the traditional, not the traditional is not the right word, but the people you tend to see in clinical who are more depressed, either actively or recently suicidal, but at the same time lucid and reality oriented, you can kind of keep a conversation going. Some of the more chronic or the personality disorders and stuff like that, substance abuse disorder, now they're sober, they tend to keep a conversation very well, and sometimes can be very social and easy to talk to. When you have more of the psychosis and mania, it can be very difficult to talk to. And I remember one time when I was in clinical, and I remember this a lot. It was me. I was in a unit that was quiet, and it was I guess I can just tell you, it was in the ACU in the back. We don't have students there anymore. Where I don't know if SEC ever did, but I played game with this patient, and then I was like, okay, it was a 20-minute game. Thanks for playing with me. And I stood up and walked to the other side of this very small room and sat down because I was done. You know what I mean? I was ready to. Okay, I played one game with this patient. I got some interaction. I was good. And 20 minutes later, sat down somewhere else and was just like, oh, that's the only person who's here. So I remember I sat there for a couple minutes, like I got 4 more hours left here, and I looked at him and he looked at me. And I was like, you want to play again? And he's like, yep. So I walked back over him, and it was me and him for 4 hours, and I think he was tired at the end of it because it was interesting because he had we're playing Scrabble, and we played like game after game, and he started like three-dimensionalizing the Scrabble board. Like it started like he started approaching it from the back, and it was like upside down, and then like the words they stopped being. It was kind of hard to explain, and then he sort of got really energetic, and then he started writing on the chalkboard and got kind of irritable and agitated, and then I don't know if somebody said, hey, go to your room, or if he just decided to go to his room and that was the end of it. So he was sort of like, you can kind of see it in his eyes, but he was holding it back and was very slowed, and he was very like years of having mania, but being able to control it by doing something like this. And then I wore him down after 4 hours of game playing, and then he got symptomatic, and then he went away. It seems like a really good coping skill for him. He was able to identify it pretty quickly, and 30 seconds later he left. But that was exhausting. I was exhausted, and I'm sure he sounded like he was exhausted too. It's exhausting to talk to somebody you really like for 4 hours, let alone somebody that you don't know and somebody who's symptomatic. So I'm talking about psychosis specifically. So that was a question I got. How do you have therapeutic communication with someone with psychosis? You're not allowed to. You can't. You can't incorporate yourself into the delusions, right? You don't want to use the delusions necessarily to try to get them to do what you want, like, oh, the voice is telling you to take your meds, right? If you sort of play into the delusions, you become a part of it, right? And they'll be like, hey, the CIA has not bugged your pillow, Mr. Johnson. There's no listening cameras in your room. It's like, well, Nick's seen them. I've shown it to him and he's seen them. And you just ask him, right? Because he's saying that because I played along, and now I'm a part of it, and now he's focused on me. Nick's a part of the CIA, right? I'm going to get sort of drug into it. So how do you respond to, these conversations? How do you respond to things you've never thought you'd hear before, in a way that is appropriate and not demeaning, not condescending, right? These are people who are just having symptoms of their disease, and so. Another example I had is I remember I just got started at the hospital, right? And I was sitting at the nurse's station, filling with training or something, and this lady comes up to the window and just starts yelling and yelling at the people in there, and it was not necessarily reality based. It was just agitation and hostility. And I remember just sitting there And she was closer to me than anybody else, but people behind me were responding to her. I was just on my computer, and I was just thinking, if I was responsible for this, I would have no idea what to say to her. And so I've certainly been in this, and there's certainly times where I hear something and I'm like, nope, don't know what I'm going to say to that, And you just, they forgive you. You say something stupid or you don't say anything at all, and you're just kind of like, and they're just like, and then you move on, If you say something, that's not appropriate, you apologize. Don't grovel. Don't be like, I'm so sorry. I didn't mean to say that. You're not mad at me, are you? Right? Just say, oh, that wasn't necessarily what I wanted to say, and I apologize. Anyway, right? Apologize and move on. If they can't let it go, then walk away. But if somebody's telling you things that are, I use reflect and I use repeat almost with everybody. And with people with psychosis, you're not playing into it. They're just repeating what they're saying. That the aliens are in my bed and they're going to eat me. There's aliens in your bed? The aliens are in your bed? They're going to eat you? Yeah, they're going to eat me. It's really scary. I was like, man, that's really scary. I would be really scared if I were you. I was like, yeah, that's why I'm sleeping on the floor. That's why I don't understand. It's like, I think if I had aliens in my bed, I'd sleep on the floor too, right? You can do that for a long time. And you can kind of pivot from there too, right? If they start yelling or getting aggressive, you're like, hey, sounds like something happened that got you really upset, and that was not my intention. Anything we could do to take a break for something? Can get you some coffee? See if that can help, and then maybe we can come back and talk about this a little later. I don't want you to be angry. I don't mean to upset you, right? Kind of pivot into that de-escalation. Even if it has to be, they start saying sexually inappropriate things and you have to be more direct with the redirection. It's like, hey, James, that's not how we talk here, right? That's not what we say to ladies. So if you want to stay out in the milieu, you just got to not say stuff like that, right? If you keep saying stuff like that, we're just going to have to hang out in your room, okay? That more, I guess I did that really calmly too. Sometimes you just have to say, James, come here, right? Sometimes you have to be that blunt and direct, especially if there's mania involved. Come here, let's go. We got to go. Come on, nope. Get up, come on, we got to go. Come here, I'll show you. Come on, man, we got to go with me. Come with me, right? Not necessarily telling him to go to his room. I'm telling him to come with me, and I'm going to walk up to his room, right? And hey, let's go somewhere else. Hey, I want to show you something. Hey, I got something for you, right? If they're, I don't know if I don't only half of you guys I talked about this, but with mania, it's okay to distract. Distraction is appropriate. It's an okay redirection. Changing the topic, changing it. In other places, it's not. It's not okay to do that, like with depression. Dementia is probably okay in some instances, especially if they're really focused on something that's not. I need to go home. My husband's outside. My husband's outside. He needs to pick me up. He needs to let me go. Let me outside, right? Maybe get some coffee or some cake or something. I don't know, something to distract them. Hey, David, your favorite television show's on, Mrs. Barbara. Let's go watch your favorite television show. So with that reading and reflecting, you can really you can pivot really into anything, and then you can go into more deeper reflection too if you realize that if there's some lucidity coming in, it's just like they're telling you about their voices and or their delusions, and there's like, and now I can't live with my mom anymore. Like, oh man, that's what happened there. It's like, well, voices are telling me to do things, and I broke her TV, and now I have a restraining order, and I don't know what to do. Now that's some lucidity there, and you can start reflecting on that more. You can kind of pivot more into more of a deeper conversation, and just and you're not doing therapy necessarily, but you can just kind of discuss how they're feeling because they've just they were just honest about it. It's like man, it sounds like you're pretty sad about that. It sounds like that makes you sad, and nothing complex. I'll give an example about the repeating reflecting that happened to me this week. I got a phone call from a client who was feeling suicidal, and the client needed just to talk about it, and it didn't need me to do anything spectacular. I just repeated and reflected. I did a little bit of investigating just to figure out the circumstances, as it was very socially triggered, and she even endorsed afterwards that she felt better just talking about it and didn't feel suicidal anymore. And it comes from that place, this very powerful place of how effective intervention is, right? It's technically a placebo, right? Even though it's not, because I did something and she felt better, but that's technically what placebo is. We think of placebo as a sugar pill, but no, the placebo isn't the sugar pill itself, it's the interventionist, right? You're not going to a vending machine and pulling out a sugar pill and taking it and hoping it does something, right? You're going to a professional, or you're going to somebody who cares, and they're listening to you, and they're discussing things with you, they're counseling with you, and then they intervene. There's an intervention there, right? It can be a sugar pill, it can be nothing. You can say, hey, the intervention was you talking to me for 10, 30, 60 minutes. And it's shown to have biological and chemistry benefits, okay? And so just the fact that you're listening to the person is good. kind of going back to interacting with that person who has psychosis. Okay, how do I interact with them? And the key is, and I said this sometimes before, is somebody who's talking to me about delusions, I just need to know two things, or voices. I just really need to know two things. One thing is, are you going to be violent because of those voices, to yourself or to somebody else, right? The voice is telling you to hurt somebody, or are you thinking, Jimmy over there is going to kill me, so I need to kill him first, right? Are those the thoughts you're having? And I need to know, okay? Because I need to keep you safe and I need to keep everyone else safe. If they're not telling you to hurt anybody, or you don't want to hurt anybody because of them, okay. Next one I need to know is, do they really are they bothering you a lot, right? Even as an RN, like I want to know, like I'm hearing a lot of voices and it's starting to make me feel really agitated, right? They're probably not saying this to you, but they're saying this to you, right? You're seeing this in the interaction. They're really agitated. They're doing fine 45 minutes ago. Now they're getting really. I was like, I can see the cameras and I know what they're looking at, right? I can see them. They can see me, right? And I gotta get out of here, man. You gotta let me out of here because they're recording me. You know, you're hearing that kind of stuff, and or as an RN, you can give them the PRN medication. Most people have PRN medication. There's a lot of things you can do. You can talk to the doctor, get them a PRN medication. It's kind of like pain, right? Pain exacerbation. You see what they have on file. If they just had it 30 minutes ago, you got to give them something else. They can't just sit there in pain. You got to intervene, right? There's non-pharmacological approaches too as well. Psychosis is hard. Mania is hard. Earphones and music and pacing is fabulous, right? Get the guy some earphones. Let them drown it out for a little bit, okay? If they're not impatient, they can go swimming. A lot of people say that they don't hear the voices when they're swimming. So there's some things you can do. Some things that I've interacted with, and I remember one time I was sitting eating at the hospital, and this patient came up and just he was pleasant, but nothing was reality that was coming out of his mouth. It was very the content was a lot of psychosis. Mostly disorganized, I think. Just wasn't like a linear line of thought. Just maybe he had it in here, but it couldn't come out here. And a staff member looked at him and said, "I don't know what you're talking about." And this kind of went on. And most people who say that would come across as really cold and really cruel, and the patient would have been hurt. But in this instance, it was not the case. It was well received. No one seemed to mind. The patient was still happy. How does that happen? How does that work? Well, this particular staff, that he didn't have any specific the therapeutic intervention or communication or motivational interviewing other than the 2-day orientation, had and built fabulous rapport with almost every patient. He absolutely did. He could get any patient to do anything because of the rapport he built, which makes me think that all therapeutic communication doesn't matter as long as you have good rapport. That isn't necessarily true, but therapeutic communication is trashed without rapport. It's completely garbage. I don't care what you say or do. If you do not have rapport with a client, or even worse, if you have bad rapport, you aren't going to get anywhere with them. Okay, and you see people who have inherently and very naturally ability to build rapport, and they do fabulously without training. And some of us fall on the spectrum, right? Some of us take some time, and some of us are going to inherently just bump heads with everyone, man. And there's so many people in the healthcare community, and I know everyone can relate to that. Just healthcare providers who just bump heads, and I wish there was a way that I could feel confident to say, can you go take a class or something? Because I think that's all learnable. I think you can reverse that. If you find yourself getting in a lot of arguments or feel really defensive when you're talking with patients, I think that you can learn. I think you can change that. It's going to be a little harder for you, and that might be frustrating, but you can definitely learn it. I'm trying to think of different things that people who I heard who are not necessarily like aggressively, but just psychotic content. One lady took me to the window one time when I was at the hospital and showed me a motorcycle and told me that she was going to give it to me. And I was like, man, that's really generous of you. And she's like, yeah. And every now and then she'd see me and say, hey, what did she call them? I think she called them leathers or something. Hey, what did you think of those leathers I gave you? And I was like, man, that was really generous of you, right? I'm not necessarily playing along, but I'm not like telling her, you don't own that bike, ma'am, and you didn't give it to me, right? That you're in a hospital right now and you're in a safe place. I didn't need to say that. Another guy, he wrote down these music chords for me, and every time he'd see me, he's like, I just like those chords, man. I was like, I like them, they're pretty cool. And he did. He gave it to me, so I wasn't, they were just kind of disorganized in it, and I didn't know music. So one lady was calling the police. She wasn't saying anything to us. She just would call the police, and it's really a nuisance for the operator when patients call the police. So the operator called me and in so many words told me to tell the patient to stop calling the police. I didn't know she was, and so I went and talked to her, and she was very paranoid and excruciatingly paranoid. I got so uncomfortable with it. I can imagine the fear that she had, right? So she was calling the police for a legitimate reason, but I think a part of her is compartmentalized and it's dichotomous in the sense that she knew that we wouldn't be like, You know what I mean? Like she knew that she was calm around us. She was able to sort of separate the two. And I think I just told her that if she calls the police again, we have to cut her off all phones. So I don't know of how therapeutic that was. I didn't do it mean. I was just like, hey, here's the deal. You can't call the police on these phones. So if you need anything, I'll do what I can to keep you safe. But I don't remember exactly what I said, but I think in so many words, I just told her that if she did it again, I think other people would have just cut her off. But I was like, just don't do it again. Please don't do it again. I'm gonna get in trouble if you do it again. And that's kind of you can do me a favor is a very useful therapeutic communication technique if you're trying to get someone to change your mind. Then they kind of put them on your team. And it's not you versus them. Hey, man, you got to do me a favor, dude. You got to stop doing that stuff, right? You got to do me a favor, man. Just go along with this, however you can relate to people. And a lot of times that do me a favor, that over personalization, especially somebody with a little bit of mania, I'll do that sometimes. I'll be like, hey, you know me, man. I'm going to do you wrong, right? They never met me before. But it somehow appeals to them, right? And I'm not being insincere. I'm not going to screw them over, but I'm trying to over appeal to that sense of humanity there. And a lot of times that can work too. I had one more example. Somebody who has more of a personality disorder, and this is kind of a challenging thing. I think of this client who had severe borderline personality disorder. So they have that manipulation there, which is not as clean as the textbook kind of says. There's manipulation and probably some malingering psychosis. Maybe it was legitimate, I don't know. But she would come up and say, the ghosts are scaring me or something like that. Or the CIA is going to come and give. And I know those malingering because she didn't have a fixed one. They kind of moved, right? As I was deflecting them, she was changing it. First it was the ghosts and then it was CIA. And it was, malingering means that she was kind of making it up. Not that it mattered, right? My intervention didn't change. But I think it naturally did in the sense that I would do more of a calming approach with somebody who's legitimately psychotic, versus this person's more malingering, maybe more attention seeking. We don't call them out and say, hey, you're attention seeking, go away, right? You still meet their concern, still listen to what they're saying. And I think what I said was, hey, that I wouldn't, I wouldn't let the CA come for you or something like that. I don't know what I said. I said something like, no, I'm not about that shit. Or I said shit in some way. I don't remember exactly what I said, but it sort of worked and she moved on. I'm not saying you should cuss with your patients around. We weren't allowed to, but in that case it worked. Where I was just like, that I wouldn't let the CIA, I'm not, I don't need the CIA in my business. I don't need them looking over my shoulder. Right? I kind of played it as a sass and I think she kind of liked that and walked off. And so, I guess I wanted to give you guys examples. I don't know if I rambled too much. For me, the consensus is rapport. Building rapport is the most important thing. If you don't know the patient, you see them the first minute, you can build some pretty good rapport building techniques in seconds. You can build rapport pretty quickly. And if that's especially that your goal is building rapport really quickly, you can do things. People can, there's a warmth and a likability you can kind of convey, even if you're not a warm or likable person. I'm not saying anybody's like that in your class, but if you find it hard, you can learn it. It's like empathy. You can't learn empathy. Yeah, you can. You can learn empathy, and actually, you can fake it. And faking it's the same thing. Okay, if you can present yourself as empathetic, you become empathetic. That's the whole definition. If you can present yourself as warm and likable, even if deep down inside you're like, right? If you can present it, I don't even care, right? That's the only thing the patient sees. You could probably argue that if it's really not there in your heart, that it somehow will come back as some sort of condescension or anger, but I don't know. You know what I mean? Maybe not. For some people, I think that we're all doing something out here that doesn't reflect in here. And if you're saying that you're authentic like that, then you're full of shit. Okay, I'm just gonna say that. I think that you present yourself in a certain way. That's all that matters. Okay, there you go. I just got ahead of you there for a second. You can fake it is not the right word. Fake it till you make it's not the right word. Learn it. Okay. I had one more. What was it? Oh, okay, so here's a little trick with somebody with borderline personality disorder, and it's the fact that every patient has. Everybody has strengths, right? Everyone has strengths, and so it's important to know that. And this one client I had, I knew that if I could make her laugh, then she would leave. She would walk away, right? And a lot of times, not everyone, and there's no science to back this up, but the people with borderline personality disorder tend to be the women tend to be women, and the more severe ones with the severe self-harm, the malingering psychosis, or the mood disorder, the substance abuse, the really complicated cases, tend to have really rich but yet warped sense of humor. Right? Really, what's the word I'm looking for? Irreverent. in their sense of humor, really dark and twisted sense of humor, right? And so you can sort of appeal to that. And I remember this one client, she would come up and say this stuff to me. I think it's the same client who was telling about the CIA or something. And I was like, she's gonna give us a hard time if I don't. And she would slam her head against the wall and you just eat up all her time that day. And so if I can get her to laugh, I don't remember exactly what I said, but she laughed and then she walked away. And I just see her all shift. And I know she came out for evening shift. I know she gave him a hard time. But there's just, you understand that everybody has strengths, right? Everyone's a person, everyone's a human, everyone has strengths and weaknesses. And those strengths are protective factors for all of our patients. So you can find them, okay, and find that they have a really great sense of humor. And you can appeal to that, right? You can appeal to their strengths, right? You can find them and identify them. It's like with suicidality and the fact that, they have, what are your reasons to want to live, right? What reasons can we find that help you be better, right? Find those strengths and use them, right? Appeal to them. And a lot of times you can just tell, and even sometimes you can kind of overstate their strengths. And I was like, man, it's kind of the affirmations part, right? I was like, you clearly care a lot about people, right? I think one guy really wanted to beat up another guy because he was slamming the phone and the phone was going to break. So I told the guy, I was like, you want to stand up for the other patients here because you don't want the phone to break, right? You care about other people here. I don't know if that's true, but I sort of said it. And he's like, I think he wanted it to be true too. So he's like, yeah, I do care about other people, And you kind of speak to it and it kind of works. So I don't know if I answered any questions there, but it's definitely a technique, and you're definitely going to say stuff that's not going to work, and you're like, whoa. And sometimes you get really embarrassed, and you just at night just started thinking about it, like this is me sleeping at night. I do this with my hands. I don't know how I do that. I'm not playing a flute, but you just think about, what if I said this? What if I said this? You can torture yourself all you want, but just learn from it and change it later. Patients don't remember. Okay? All right. They do remember. They remember that you cared about them. They don't remember exactly what you said, or if 1 out of 10 times you said something dumb. That's it. That's all I have. Oh, I was going to say something about grief and loss, but, what do you say? This is the same thing. It's hard when you don't know what to say. And for me, that's absolutely with grief and loss. Someone just dies. I absolutely have no idea what to say. So I try as hard as I can not to give advice. I try as hard as I can not to say at least. I try to just reflect, repeat affirmations. You really care about your mom, right? And your mom deserves that you care about her, and I know you're feeling really sad right now. You've been feeling sad for really, really sad for months, but you're grieving, and your mom was a special person, and she deserves that grieving, right? She deserves people to remember her life. And then I try to get them to talk about something that they remember good. I'm usually only talking to people for a brief amount of time, so I was like, tell me something that you remember about your mom that you liked, right? Even though it was hard. Tell me about it. What was your best memory with your mom, right? Let them kind of remember the positive or the negative, and then I was like, thank you so much for sharing that with me. I really appreciate that. And then it's, we're not doing therapy with them. You don't have to be with them for 45 minutes to an hour. It could be a 5, 10, 15-minute conversation. And honestly, I do therapy for 60 minutes, and I don't always necessarily find it any more effective than the 15 to 30-minute interventions. And so it can be very, very effective. So, okay, that's it. Bye.